And thank you for taking the time this evening and attending this webinar. It's much appreciated. Just to begin, this is the slide to show you the KwaZulu-Natal pathologists with our CEO, Dr. Ibrahim Hussein, as well as Dr. Priya Pillay, who's our regional managing partner, and thereafter we have all our pathologists ranging from chempath, hematology, microbiology, and histopath. And you're welcome to have access to this to be able to contact any one of us in each department should you have queries. So today's topic, hand, foot, and mouth disease. And many have asked, why have I chosen to speak on this topic today? And the reason is, let's go back to when the story started. And a media statement was released by the Department of Health around the 14th of Feb. And here we had around 6 cases. The first 6 cases were reported between the 6th and the 10th of February. And the number of confirmed cases had then risen to around 36, which had alarm bells ringing. So at this stage, an outreach team from the department visited 9 affected schools to investigate the outbreak. And in all instances, the learners were found to be suffering from malaise, flu-like symptoms, and what was described as blisters on the hands and swollen hands and sometimes swollen feet. And the affected areas or learning facilities were in the north of Durban. So it was in the Phoenix area, Greenwood Park, and Umhlanga. And today we were actually lucky enough to meet one of the family practitioners that was instrumental in seeing a number of the children from one of the affected schools. And he said that he feels the numbers are much higher than what was reported initially because he had seen so many patients. So I was very lucky enough to speak with the Director of Environmental Health, Communicable Disease Control and Malaria Control in KwaZulu-Natal this week, Ms. Babongile Mhlongo, earlier this week and as well as today. And she was generous and kind enough to share the newest numbers on hand, foot and mouth disease in KwaZulu-Natal with us. And she has also provided us with slides that they have just been working with that I just got actually just a couple of hours ago. So currently from that initial 36 cases, we are now sitting at 680 cases, with the eThekwini district being at 446 cases, with around 36 admissions. Thankfully, the admissions are because the children are not able to swallow, and they're not able to feed. So it hasn't been severe disease or severe complications, but rather maybe dehydration or the inability to feed or take medication. So that's why those kiddies have been admitted. So the cases emanate from primary schools and daycare centers. And when looking at the stats, urban versus rural areas, there has been a decreased reporting from query rural areas, but this could be not that the disease is not happening in those areas, but it could also speak to transportation and access to healthcare and the recording of diseases in those areas. Are those children actually being brought to seek healthcare? Because most of the cases have been mild. So thus far, the hand, foot, mouth disease, it's not a notifiable disease. Therefore, the stats may not include all the cases. There is a DOH line list that is available to all doctors that do encounter patients. And these are the email addresses of the people to contact should you require to populate that line list, because that is how we are getting the stats. And then you email that line list back to these relevant people. So these are now the slides that Ms. Mhlongo shared with me earlier today, and it's looking at the updated data. And here we can see the epicurve of hand-foot-mouth disease by symptoms onset. And it, as we said, it started sort of late January, and the cases then started to peak by mid-Feb, and we even had sort of around 30, 35 cases around the end of Feb. The curve is looking as if it's tailoring down, burning out, but this could also mean that cases are not being reported. So we are not, but it is a good sign that the number of cases are decreasing. So breaking it down into the districts in KwaZulu-Natal between Jan and March, as we can see, eThekwini is sitting at 446 cases, the highest number. And thereafter, there's much fewer in the other districts, with a total number at 680. And we looked at the admissions at being around 36. Looking at the age breakdown, because normally this disease affects much younger children. About a third of them, we have, there was no age that was documented. But if you're coupling the grade RR and grade R, so the 5-6 year age group, as well as the grade 1, grade 7 age group, that forms sort of the bulk of the patients. We were also finding patients reported in the high school sector, and quite a few in the daycare. And we did have adult patients as well, adolescents and adults as well. So here the breakdown further into the cases by age and sex. So in terms of male and female, there isn't much difference. But as we can see, that age group, sort of less than 9, is where the highest number of patients were found. And then going up into the higher category of the grade 7s, 10 to 14 years, the adolescent group, and then some adults as well. So that gives us an idea as to why this topic was chosen to discuss, and there have been a number of clinicians that have asked for more information about this disease process. And the overview, therefore, will include a brief introduction, brief virology of this disease, looking at the pathogenesis, the epidemiology, and more so I'm placing more emphasis on how this disease is transmitted, looking at the clinical features, some of the diagnostics, management, and very importantly, the infection prevention and control, because this is the mainstay of the management. So hand, foot, and mouth disease is a clinical syndrome that's characterized by oral lesions or oral enanthem, as well as skin lesions, so maculopapular, or a vesicular rash of the hands, feet, and possibly other areas. And what we've been seeing in KZN is a lot of the elbows and the knee area that's affected as well. So it's one of the most recognizable viral exanthems in children and adults. And it was first described in a summer outbreak in Toronto in 1957. That particular outbreak was caused by Coxsackie virus A16. And since then, we've had around 15 or so other enterovirus serotypes that have been shown to cause this disease, as well as the Coxsackie virus A serotypes. So as I said, just looking briefly at the virology, the enteroviruses are a genre of the Picornaviridae family of viruses. So this would include polio, Coxsackie viruses, echoviruses, and rhinoviruses as well. With the enteroviruses, there's around more than 100 serotypes, but here the A71 serotype has been found to be closely associated with hand, foot, mouth disease, and it is also associated with outbreaks in Asia. And as well as, it is rare, but it can be associated with more severe disease as well. With the Coxsackie, it ranges between A2 A4 to A10, where the A6 category or serotype is actually associated with quite severe disease, the cerebral disease, and it's associated with outbreaks in the US. Here, the most common serotype associated with hand, foot, mouth is A16, and then it also ranges from A24, B2 to B5. And then echoviruses, these are the serotypes that can be associated with the skin and mouth lesions. So what is the pathogenesis? Primarily, the human enterovirus infection occurs after oral ingestion of the virus. So virus that is shed from the GI tract or the upper respiratory tract of someone that's infected. So it means ingestion of fecal matter, oral secretions, or respiratory secretions. That is the primary method of transfer. So infection may also occur following contact with vesical fluid or oral or respiratory secretions into possibly open areas of the skin. And the virus may be detected, this is important, for about 6 weeks post-infection, and sometimes for several months after infection as well, depending on how that patient clears the infection. And the duration of shedding from the oropharynx and the upper respiratory tract is much shorter. That's usually about 3 to 4 weeks. Prolonged shedding in the stool, as well as its ability to have environmental stability, favors the transmission of this virus. So in terms of the pathogenesis, there's a two-step or an initial multiplication process and a secondary multiplication process that is noted. So once the virus is ingested, as we've described, they replicate in the submucosal lymphoid tissues, in the lower intestinal tract, and then also in to a lesser extent in the pharynx. Following replication here, the enteroviruses then spread to regional lymph nodes, and this is when the minor viremia or the first viremic phase occurs, and where there's dissemination of the virus throughout the body, resulting in infection of the reticular endothelial tissues and multiple organs. So you'll have CNS, heart, liver, skin affected. And certain serotypes have a predisposition for certain types of organ systems. Once reached at those organ systems, there's replication at these sites, and this is then responsible for the clinical manifestations that are seen. Further replication at the disseminated sites results in a secondary or the major viremia, and this can continue until the host produces type-specific antibodies, so your IgG, IgM. Enterovirus replication in the organ tissues, if left unabated, can result in death of infected cells with accompanying inflammation and necrosis. So the epidemiology of hand, foot, mouth disease, where does it occur, how does it occur? So it occurs worldwide, and outbreaks involve daycare centers, schools, summer camps, hospital wards, military institutions, and communities in general, and that is what we've been seeing in this current outbreak. There's intra-family spread occurring, where usually the younger or infant children get the infection from a daycare center or a creche, and thereafter you have the infant siblings and then the younger children being affected, and then usually the mom and the dad or the caregivers being affected as well. So it's primarily in infants and children, particularly those less than 5 to 7 years. And you can have sporadic cases and epidemics occurring in older children, adolescents, and as well as adults, which we are seeing currently. When does it usually occur? So during the summer months, autumn months. However, we have had outbreaks and sporadic cases occurring during the winter months. And in tropical areas, we find hand, foot, mouth disease occurring during the rainy season. So with the global warming and climate changes, temperature and humidity have been found to affect hand, foot, mouth disease, which is raising the possibility that could global warming and climate changes be affecting this disease process and causing outbreaks as well. What was found during our COVID pandemic is that there was a decrease in the number of cases of hand-foot-mouth disease due to the enterovirus A71, which is one of the most common ones causing this disease. That was observed in China and Japan, and that was thought to be due to all the non-pharmacological measures that were used to prevent COVID, and therefore it was also preventing enterovirus spread. So with regards to transmission, we've talked about the fecal-oral or the person-to-person spread. There can be contact with the oral respiratory secretions or the vesical fluid. And we've spoken about stool shedding occurring, or shedding of the virus in stool occurring, much longer, like around 6 weeks to 10 weeks post-infection or post-symptoms. And the respiratory tract shedding is much shorter. And this is important because with the younger children, and I've highlighted in terms of how the disease can be transmitted in the creches and daycare centers is via shared surfaces. So with the younger children drooling, etc., and touching of shared surfaces, stationary toys, cups, utensils, etc., that was a prime method for transferring this infection. So we've already spoken about the PCR methods of detecting virus in the stool and respiratory tract secretions, but traditional methods that would be via culture, for example, which is not usually done due to the increased amount of facilities, etc., that are needed for culture. But traditional methods have also found viral detection demonstrated in the stool for around 4 to 6 weeks, and similarly for respiratory tract shedding for about 3 weeks. But what's important to note is that you can continue to have shedding long after clinical signs of illness, and this is where I think most of the transmission is occurring. Of note are the environmental sources and how that plays an impact. And in South Africa, there have been studies that have been done showing that hepatitis A, adenoviruses, astroviruses, noroviruses, and enteroviruses, rotaviruses have been detected in surface water, in wastewater treatment plants, and in treated drinking water sources in some provinces in South Africa. So this is worrying because should there be a breach in terms of the providing safe water, drinking water, is that a possible method of transmitting enterovirus? The sewage systems, if, for example, improperly treated, and then the sewage then leaking into other water, for example, seawater, you can then get contamination that way as well. Also, what's noted is a clustering of the enterovirus in families, and this is noted with this particular outbreak, where infants in diapers are the most efficient disseminators of the infection, because it then follows through for the caregiver and then spreading to the rest of the family. And the period of contagiousness corresponds with the period of how long can that patient actually excrete the enterovirus in the feces. So what is the incubation period? It's typically around 3 to 5 days, but it has also been reported to be as short as 2 days and as long as a week. So there have been children that have been ill for around a week and sometimes even longer than that. So I want to spend a bit of time on the clinical features because this is where we are getting the most questions. I have a child in the rooms. They have what looks like hand, foot, and mouth. Can we assist with that? So with regards to the presentation, usually there will be, in children that can speak, they complain of painful mouth, painful throat, and the younger children just aren't able to eat or drink. And this is due to the oral lesions. If there's fever, it can be around 38.3, and you can have the prodrome that most patients do have, which is fever, fussiness, irritability, abdominal pain, and even vomiting and diarrhea at this stage. And thereafter, the oral lesions and skin lesions may come through. With the examination findings, the hand-foot-mouth, as I said, has an oral enanthem as well as a skin or an exanthem. But patients can have just the oral lesions on their own and the skin lesions on their own. So it can be one without the other or both together. So let's have a closer look at what these lesions look like. So with regards to the oral enanthem, they are found anterior to the facial pillars, and most commonly they're actually found on the tongue and on the buccal mucosa itself. And they present as erythematous macules, which can progress to vesicles that are surrounded by a halo of erythema. They have smaller types of diameters in the mouth, which is 1 to 5, but they can actually become quite large. They can coalesce, and they have a grayish or yellow base. And when they coalesce, then they tend to cause lots of problems, lots of pain, and difficulty eating and swallowing as well. With regards to the exanthem or the skin lesions, this has been associated, or the type of exanthem, it can be different types of lesions. So you can have macular, maculopapular, vesicular, or you can have all three in the same patient. So I think this is where the confusion was coming in, because some patients were having just macules and then that was disappearing, or just vesicles and that was disappearing, which then brought into what could then be the differential diagnosis, which we will go through. Here as well, the vesicle diameter could be between 1 to 10 millimeters, but here as well, it could be filled with turbid fluid or even clear fluid. And this is actually, when we look into diagnostics, to de-roof a particular lesion like that, to be able to take a dry swab and swab that clear fluid or that turbid fluid to be able to send it off for PCR. It also has a halo of erythema, and the atypical morphologies, it could look like purpuric or petechial or even eczema or type lesions. And the typical area, as we said, is on the dorsum of the feet, as well as on the soles and the palmar surfaces. So here we see that palmar surfaces, as well as the dorsum of the hands and the feet, seen also on the thighs, the buttock area, and we've been seeing a lot on the knees and the elbows. So the skin lesions are typically not itchy, and they're usually not painful, but if they are of the Coxsackie virus A6 serotype, then children were usually complaining of painful lesions, but the majority of them were not itchy and not painful. They usually resolved in around 3 to 4 days. So we've gone through the regions that have been affected on the body, and the lesions in the buttocks were mainly maculopapular rather than vesicular, and this occurred very frequently in infants and younger children, as well as older children and adults. But I'll show you, these were the typical sort of textbook images, but I'll show you what we were also seeing. And what's important here to note is that these, once the vesicles had burst, there was a chance of having a secondary bacterial infection. And this may have then spurred some clinicians on to start off on antibiotics. So these are pictures of one of our colleagues who graciously shared these with us, where she had not one of her children being affected, but all 4 of her children being affected, and each one of them presented differently, with the youngest being the most mild, and then with the older children, they had more severe symptoms. And here we can see how it doesn't really look like much on the foot, but you have to actually examine and look for those macules on the plantar surfaces. Even with the vesicular lesions, there were very few for some of the children, while some of them had even more. So you have to actually search for these lesions on your patients. So once again here, the interdigital as well as on the palmar surfaces. And here on the palmar surfaces, there were very few scattered macules. And also here on the foot, there was vesicles and very few macules. But then these tended to become more as time developed for these patients. So how the lesions looked as they were healing. So this was typically how it looked on the elbow, with vesicles that have now burst and scabs have formed. And here, this is a macule on the foot, and now it's looking at the same lesion completely healed, and most of these lesions have completely disappeared in these patients, and no scars have been left, thankfully. So looking more particularly at the enterovirus A71 as well as the Coxsackie A6, because these are the two most common serotypes causing this disease. The A71 has been associated with severe illness. And here, when we're speaking of severe illness, it was CNS disease, rhomboencephalitis, acute flaccid paralysis, aseptic meningitis, and pulmonary edema, pulmonary hemorrhage, and cardiac failure. And of note, to mention, we've had around 3 enterovirus meningitis cases since the beginning of Jan. But when we looked at the history and how these patients presented, none of the enterovirus meningitis patients had hand-foot-mouth disease presentation. So they presented straight on with meningitis symptoms, and didn't develop any rash during the course of their illness. With the Coxsackie A6, as I said, this is more in the US, causes of outbreaks there, and associated with severe disease both in children and adults. And here they have higher fever, a more wider distribution of the body, which might even include the groin, perineum, and areas of active or dormant eczema. And there's more extensive skin involvement with bullae, erosions, ulcerations, vesicular bullous lesions, and eschar formation as well. Much longer duration with palmar and plantar deformation, and also nail dystrophy, where there's damage to the nails, transverse ridges on the nail plate, or even shedding of the nail 1 to 2 months after the disease. So that's a much more severe picture, which is not what we were seeing in the KZN patients. So what are the complications that we can see? We've already alluded to some of them, but the main reason, as I said, for admission in the patients that we've had is the decreased oral intake, and this then results in dehydration, which then will necessitate hospitalization for fluid therapy and for taking medication. The other complication that can be seen is brainstem encephalitis or rhomboencephalitis, acute flaccid paralysis, aseptic meningitis, myocarditis, conjunctival ulceration, which is rare, and the onychomatosis or the shedding of the nails. As we said, that's more linked to the Coxsackie virus A6 and the more atypical type of presentation. So I thought it was important to spend a lot of time on the clinical features to be of some assistance in diagnosing this should patients present to you. When we're looking at the diagnostics, what is available, I think foremost we must note that this is a diagnosis that is made clinically. So when you put together the oral lesions, the skin lesions, coupled with the prodrome or coupled with the history of another child at home being ill or a school exposure or a daycare center exposure, then that is your diagnosis. Confirmation of specific virology is rarely necessary in these patients with uncomplicated hand-foot-mouth disease. And usually we would look to diagnostics when the diagnosis is uncertain and when you would then affect management. For example, if you are confused as to whether this is a herpes simplex or whether it's a varicella versus a hand-foot-mouth, and you need to do a swab to find out, is it could you now treat with, for example, acyclovir or valacyclovir? That would be where diagnostics is necessary. And what would you use to diagnose? It would be throat swabs. A stool can be used because enterovirus is shed, quite heavily in the stool. The vesicular fluid, as described, to de-roof a vesicle and send a dry swab, and this should be then obtained for PCR. And this is much preferred to cell culture because cell culture takes, much longer days. You require, specific cell. It's much longer than a PCR because with PCR you can actually get it within hours. And once identifying enterovirus from vesicular fluid or CSF, as in the enterovirus meningitis cases, that confirms the viral etiology of hand-foot-mouth disease, or in the cases of the meningitis, enterovirus meningitis. And identification and isolation of enterovirus from the stool or the throat does not necessarily mean or establish causality. For example, if a patient does not have any symptoms and you're isolating enterovirus from the stool, it could just mean that they've had disease and they're now shedding. So that is what the last point speaks to as well. So looking at what diagnostics we have available and where does it fit into the picture of your patient. So number one, the enterovirus PCR from blood, or be it from your vesicular fluid, or even the stool. For example, the enterovirus PCR in blood can be picked up within days of infection, and the same goes for the vesicular fluid. Your enterovirus PCR from stool can go on for a number of months, for days, weeks, and a number of months. We will then speak to serology. So serology, you would now have to wait, as we spoke about the pathogenesis. There's the initial mild viremia, thereafter there's the major viremia. You're then going to have to wait for the body to kick in for a host, a specific type response, and that is when you'll have the IgM as well as the IgG mounting, and this can also be weeks to months of being able to be detected. The information that's on these slides is available on a lab update, number 39, an AMPATH lab update, which can be made available to you as well. So this table is also from the same lab update, and it's looking at all the enterovirus lab tests that are available. So as mentioned, it's not necessarily that we need to do this for every hand-foot-mouth disease patient, but I wanted to illustrate to you what is available. So here the enterovirus PCR on the blood, serum or plasma, eye swabs, vesicle swabs, but best to do it on a de-roofed lesion. Fluid, for example, if there's respiratory symptoms, tissue, if you're going as far as doing, for example, a biopsy, and then stool, which is the most non-invasive specimen. The CSF, well, the enterovirus meningitis cases we diagnosed on the viral meningitis panel, or which has a number of pathogens on it. And that is where we detected the enterovirus, but you can do enterovirus PCR alone as well as a single test on CSF. On respiratory panels as well, it can be done on a number of respiratory specimens, and here as well it will form part of your full respiratory panel, or it can be ordered on its own. And then we spoke to the serology, which would look to IgA, IgM, as well as IgG testing. Ideally, the serology, because it takes so much of time, you would then want to look for any rise in your IgG titer, so that would then require a further follow-up specimen. So for a quick diagnosis, it's usually the PCR. So the other important part that I want to look at is what else could it be? Because we were getting patients that had other symptomatology, or symptomatology that was similar to hand-foot-mouth disease, but it could have been other disease processes or causative factors. So if we're breaking it down into pruritic lesions, what else could it be? So it could be something as simple as insect bites, scabies, varicella, herpes simplex virus with the vesicles, measles, contact dermatitis, allergic dermatitis, even mpox. With regards to the mouth lesions, um, you know, this could also be a number of things with viral pathology as well. So viral pharyngitis, measles with the typical coptic spots, or herpingina, which has much the same viral etiology as hand-foot-mouth disease, but the majority of or all the symptomatology is in the mouth with coalescing lesions and very painful mouth lesions. And then there could also be aphthous ulcers. So what I have is just put together a table, and this is from Medscape with some further information in it to give you an idea as to what else could it be. So we've gone through hand, foot, mouth and how the lesions develop. So it starts off with papules, vesicles, and then that can then move into the maculopapular stage as well. What areas are affected? So the mouth, tongue, pharynx, and the arms, buttocks, genitalia even, with low-grade fever. With the herpingina, as I mentioned, this is very similar viruses, the Coxsackie echovirus that's causing herpingina. And the severity of the illness can be quite severe because these lesions can actually become secondarily infected, so they can have very high fevers. And just having these viruses alone can cause high fevers, and the children don't feed well, and they aren't able to swallow, and you might have to admit these children as well. And here it's posterior oral cavity, tonsil, soft palate, and the uvula that can be affected. With the hepatic gingivostomatitis, this is herpes simplex, also moderate to severe with vesicles and ulceration in the mouth, with the lips, gingiva, and the buccal mucosa being affected. Very high temperatures, and here you would also find lymphadenopathy. The aphthous or stomatitis or the aphthous ulcers causes unknown. Here it's very mild to severe. You might have ulcerations, and it can be associated with other viral enanthems as well. The lips, tongue, buccal mucosa is affected, but it's not usually so severe. Patients remain afebrile and are quite happy, and you can have this recurring in children. And then one of the others to consider is Stevens-Johnson's, which is an immunologic type disease process. Here, this is much more severe or moderate to severe with vesicles that might actually ulcerate, also with the mouth, much of the mouth being affected. But here there's the targetoid or target-like cutaneous lesions with diffuse mucous membrane involvement. Usually these patients require a hospital admission with physician and dermatology consults required. So looking at the respiratory virus stats. So what stats I have shared with you, as I said, what the Department of Health has kindly shared with us. But looking at our AMPAT stats and what we were noticing in terms of the introvirus over the December-January period, we found that there was a slight uptick of introvirus, and this was in children that were sampled with our multiplex PCRs. So we were finding increases of introvirus either on its own or with the rhino introvirus, because it's in that Picorniviridae family. We can pick up rhino intro together. So we were finding an increase in these respiratory specimens. So then we would move on to management. And management, once again here, just like how diagnostics, it's primarily a clinical diagnosis. Similarly, management is mainly supportive. Children with complications may require hospitalization. And as I said, from around the numbers that I got, around 660 odd patients, we had what was reported at around 36 odd hospital admissions, but these numbers are also changing. What's important to note, we were often getting asked the question about should we start acyclovir, but the genome of the enteroviruses does not encode for thymidine kinase, which is the enzyme necessary for acyclovir to actually work. And with trials, it was found that there was lacking evidence in terms of acyclovir for hand, foot, mouth disease. So in terms of should we start acyclovir, the answer is no. Also, we mentioned why patients needed to be admitted, and this was for adequate hydration. Thankfully, none of these patients had severe complications, be it neurologic or cardiovascular. But our intravirus meningitis, those were separate and they were admitted. Supportive care in terms of managing pain, fever, and discomfort. And these patients actually responded quite well to IV fluids and IV meds. By the next day or the day after, they were actually able to play and feed. And what's been noticed is that not to use sort of lidocaine or local anesthetic or topical therapies on the lesions to coat the lesions or to look at soothing the pain in that regard. That's not recommended. I feel I must mention, as a microbiologist, I must mention antibiotics sometimes were started in patients, and this was due to possibly the infections becoming secondarily infected, be it in the mouth or be it on the skin. But generally, if it was a mild case, there was no need for antibiotics. To share with you, should you have a patient that comes into your rooms or you consulted for, there is a case investigation form for hand, foot, and mouth disease that is available on the NICD website, and it takes you through all the information that is required, together with what exposure history, what you were seeing on the patient, as well as what laboratory tests were done, and what clinical management and outcome you were seeing. As mentioned, there's also the line list that is available from the I will share that once again with you, the email addresses of who to contact to get the line list, as well as to who to send it to. So speaking about treatment, antivirals, antiviral therapy for enterovirus is more for the severe cases. And I'm not advocating antiviral therapy for hand, foot, and mouth, because most of the infections, as we've said, have been self-limited and they did not require specific therapy. When you're looking at very life-threatening, potential life-threatening exceptions, where you have fulminant neonatal infections, severe myocarditis, disseminated infections, patients with, for example, immunocompromised hematologic malignancies, then we may have to consider what else is there. Unfortunately, the therapeutic options are very limited. And usually here it's, for example, if there's hand, foot, and mouth, but if there's also another severe illness that has required them to be admitted, and if we are finding progression of the enterovirus symptomatology or progression of the patient or worsening of the patient's symptoms, despite the patient being on adequate supportive therapy, then you might have to consider this. Or what else was found is if the patient, for example, had a bacterial meningitis and then also had an enterovirus meningitis, and patient was on adequate antibiotics but was still not responding, then maybe there is a place for an antiviral. And here the antiviral that has been looked at is a capsid inhibitor, which is this particular section 21 agent, which is the pleconazole. It's a capsid inhibitor which prevents the virus from actually attaching to the host cell and uncoating and then releasing its nucleic acid. But because of its limited availability, it actually restricts its clinical utility. But this is something to keep in mind should you have a patient with very severe, serious enterovirus infections. I want to look at briefly the infection control, infection prevention and control, because this is where this is paramount and it is actually the mainstay of treatment. The NICD has actually put out a very well-structured document, which can be found on the NICD website at this link. And primarily, it looks at infection prevention control in healthcare settings. And here, it's it's quite clear in your mind, but it's good that it's highlighting it, that it should be hand hygiene. So your healthcare workers must practice frequent hand hygiene, hand washing with soap and water, especially after patient contact, handling bodily fluids, and touching contaminated surfaces. And should hand washing not be able to be done at that moment, it would be alcohol-based hand sanitizers. But should hands be visibly soiled with secretions or stool, for example, when changing diapers, then that needs to be washed immediately. PPE would be looking at gloves or aprons when handling fluids or changing diapers, or cleaning contaminated surfaces. Face masks are recommended also by the CDC in 2024 when looking after patients with respiratory infection as well, for droplet prevention of droplet transmission. Patient isolation and cohorting. This might not be possible to isolate every single patient, but you might then be able to cohort symptomatic patients in separate rooms or sections of a hospital facility. Environmental cleaning and disinfection, specifically targeting high-touch surfaces with disinfection at least twice daily with an approved disinfectant, and this has been thought to be the sodium hypochlorite or the bleach. And medical equipment must also be cleaned and disinfected between uses. Then more specifically, they broke down IPC measures to how to do this in schools, because this is where we were seeing it affecting the patients mostly. So hand hygiene and respiratory etiquette, where staff and students were taught how to wash hands, but also how to have proper respiratory etiquette, coughing and sneezing, for example, into a tissue or into the elbow, and then hand washing thereafter, and also hand washing after meals or using the restroom. In terms of monitoring and excluding children from school, it was thought that to keep children away from school when they were symptomatic, when they had fever, and once the fever had broke and once the lesions or the blisters had dried up, they could then return to school. And it was important for schools to identify symptomatic children to be able to then ask their parents to come through and take them home to prevent spread in that school. So disinfection of shared spaces, we've spoken about this, to clean shared toys, books, learning materials, and high-touch surfaces in the classrooms as well. Specifically for daycare or childcare centers, the hand hygiene and diaper changing practices were extremely important, to wash hands before and after diaper changes, feeding and assisting children in the restroom. Here, the isolation and exclusion policy, I think it's easier to say, but sometimes even harder to do. Here, to separate children until they recover, or maybe discuss with the families about keeping a child at home until they are no longer having fever or lesions that are sort of discharging fluid. The cleaning and disinfection of toys, shared objects, once again, as well as looking at bedding and sleeping mats, required cleaning and disinfection regularly. And waste management, this is across the board in schools and hospitals, etc., needed to be properly disposed of in sealed waste bags. So in terms of prevention, we've touched on all the crucial elements, looking at environmental cleaning, hand hygiene, proper PPE usage, early identification of cases, and containment of infected cases so that you're not spreading in that institution. With regards to vaccines, there's currently no vaccines that are being given in South Africa or in KZN for that matter. There are, just to touch on what vaccines are available, because in Asia, China, there's a lot of outbreaks. There have been 3 inactivated enterovirus A71 vaccines that are licensed in China. And they, through trials, have shown to have high protective efficacy against the predominant C4 genotype circulating in that country. And the efficacy of these vaccines in other parts of the world is unknown because it hasn't been used in other parts. And there are inactivated enterovirus A71 vaccines that are currently under investigation. So to conclude, I think the Department of Health has put out those media statements, and essentially there's no need to panic. The number of cases, yes, they have been fairly high in KZN, but the outbreak remains under control, and at the current moment, there's no serious public health threat detected. There have been, healthcare workers, parents, caregivers have been urged to be vigilant and recognize the signs and symptoms. The infection is quite self-limiting, and it clears without medication within about 7 to 10 days, or just supportive care within 7 to 10 days. And hygiene practices, as highlighted, are the most effective preventative and control methods to control the spread of disease. It is not a notifiable medical condition at this time, and the Department of Health will remain on high alert to monitor the number of cases in KZN. And I want to thank and acknowledge once again Ms. Babongile Mchlongo, who helped greatly in terms of the stats that the DOH is actually currently working on, but she was able to share those stats with us.